Our first speaker is Elizabeth Nichols. She was an undergrad at Duke, and then she went to the University of Maryland Medical Center, graduated in 2004. She did a residency in radiation oncology, and she's still there. She's an assistant professor at the University of Maryland, the Marlene and Stuart Greenbaum Comprehensive Cancer Center. And her title today, TRACO, Introduction to Radiation Oncology. Liz.
All right. Well, thank you all for having me today, and I will make sure to try to use the mouse so everyone who's online virtually can follow along with us as well. So I have no disclosures. So the outline of our talk today is first to review just some of the general goals of cancer therapy, and then also some of the goals that are specific to radiation therapy. We'll then briefly talk about some of the basics of radiation oncology, specifically touching a couple slides on the physics of radiation, radiation biology, and then we'll have as well as some of the different techniques in radiation therapy. I'll then discuss a couple common patient presentations, and then also some of the future directions of radiation oncology, which are quite exciting and I think might permeate through some of the additional lectures in this course as well. So just if we start off by talking about, well, what are some of our principles of cancer therapy? You can see the bullet items here. So in general, everything we're doing is trying to hit at least one, if not several of these bullet points. So the first one is minimizing therapy. So we always want to minimize our toxicities from therapy, minimize the amount of time patients are coming in and out of our offices or the hospital, as well as minimizing the costs of therapy overall. We're also trying to minimize the negative impact on patients' quality of life, again, through toxicity, also maintaining as much function as patients can, and then depending on the type of cancer, also maintaining patients' cosmesis. So for example, a head and neck cancer where someone has to have a portion of their face removed, we're really trying to minimize that. We're also, of course, trying to improve quality of life. So many of our therapies are also focused on palliation of cancer-related symptoms. So again, the majority of cancer patients that we treat end up developing, or not the majority, but many of them end up developing metastases, and how can we help those patients live the best quality of life? Also looking at organ preservation. So in bladder cancer, for example, are there ways that we can preserve the bladder without taking it out? We're also trying to minimize the impact on quantity of life. So again, looking at cures and remissions. And then ultimately, all of our research tends to focus on improving outcomes, whether it's actually cancer cure outcomes or again, improving some of these other parameters that I just mentioned. The discipline of radiation oncology, we generally think of it into three different disciplines, which all kind of intersect. So radiation biology, radiation physics, and then as well as therapeutic radiation as well. So if we just do a couple of the basics of radiation oncology, so if we actually look at what is the definition of radiation, so it's the complete process by which energy is emitted by one body, transmitted through an intervening medium or space, and then absorbed by another body. There are multiple types of radiation, and so this is one of the classic slides I show. So this is demonstrating a couple different types of radiation. So you see here alpha particles, beta particles, and gamma rays, or as well as photons. So alpha particles are actually the weakest particle. They can actually be stopped by a sheet of paper. So if we actually think about the Fukushima disaster that happened several years ago, one of the things that we told people to do was actually to wear clothing, long sleeves, long pants. And the reason for that is that you can actually block alpha particles with something very thin. Beta particles are the next strongest type of particle, and they can be basically stopped by a sheet of aluminum. So some of our liver-directed therapies we use now, like sear spheres, use beta radiation. And then gamma rays, which are usually kind of our mainstay with technology such as the gamma knife, as well as photon therapy. And those actually need layers of concrete to stop them. When we look at the electromagnetic spectrum and we talk about radiation therapy, we're looking all the way over in this end of the spectrum here, so with gamma rays and X-rays. And then when we talk about, well, how are X-rays generated, the basic functionality of a linear accelerator, which you can see here on the right, which is how we deliver radiation therapy now, it all ends up going back to somewhat of this simple model where you have an anode and a cathode in a vacuum chamber. You put electricity through that, and then that generates electrons. So what are the different parts of a linear accelerator? So if I flip back to this slide here, so this portion of a linear accelerator is sometimes actually behind a wall. So patients may not actually see this, but this is where a lot of the different components are located. Here is what we call the gantry. So actually the radiation comes out of the head of the machine here. And this whole piece can actually rotate around the patient in 360 degrees and deliver radiation from any of those angles. Patients then lay on this table here, which actually the modern linear accelerators have we call this a couch, can actually move with 6 degrees of freedom, so in, out, up, down, side to side, and now we can actually do rotational changes as well. And then in addition to that, this whole apparatus can actually rotate in a 180-degree arc around the linear accelerator. So linear accelerators can produce high-energy photons as well as electrons. They have what we call uniform beam characteristics. So if we actually were to map out the radiation dose as it exits from the head of the machine, it would be equal as you go from left to right. We have the ability to do precise field shaping. And so what's actually depicted here, this is what's actually in the head of the machine. So the electrons come in through this electron tube. And then there's a bending magnet, which flips them around and then has them come out through the head of the machine. And actually in this head of the machine, there's actually numerous jaws that actually move in different directions, which can help shape that beam based on how we determine it from the treatment planning. We're able to do precise delivery because of the gantry rotation, the couch rotation, and then we also immobilize our patients, and I'll show a couple pictures of what that can look like. So when we talk about some of the radiation therapy basics and how we're doing our treatments, we talk about a couple different parameters. So one is what's called the GTV, which stands for gross tumor volume, and this is what we define based on our CT planning. We then have a concept called a CTV, which stands for the clinical target volume, and this is typically a margin added around the gross tumor that we can see, which can account for microscopic extension, because again, we're doing all of our planning based on CT and sometimes fused other images like MRI or PET scan. And so we certainly know that at a microscopic level, what we see on the CT may not exactly correlate with what's in the patient. We then talk about something called a PTV, or a planning target volume, which is an isotropic margin, which will account for setup uncertainty, and then also an ITV, or internal target or tumor volume. And we can actually draw this based on tumor motion with respirations. So we actually have the ability to do what's called a 4D CAT scan, where we can actually trace respiratory motion for patients. When we talk about different radiation planning techniques, did this skip around? I'm sorry. Is this following along correctly with the slides for you guys? Yep, okay, I just want to make sure. When we talk about radiation planning, there's a couple different techniques that we can utilize. So there's 3D conformal radiation therapy, where we use a CT to plan from the anatomy, and this allows multiple degrees of freedom for the patient. We basically create a virtual patient from this technique. And we also have a technique called IMRT, which is a little bit more of a complex planning algorithm. It stands for intensity modulated radiation therapy. This has a dose cloud and is a little bit more complex in what we call inverse planning. And so what that means is we actually can tell the computer, I want this dose to my target volume, I want this dose to my organs at risk, and the computer will actually create a plan that actually accomplishes all of those different goals. So here's another little picture. And so what this really depicts is, so if we have here a different target volume, which if you can see, I'm drawing in red here with the arrow, and then we create multiple different beams. And basically what happens is the computer system can create a radiation plan looking at that specific angle and blocking out organs that we don't want to treat. So for example here, this could be a prostate patient. And so at this beam angle, you're going to have this type of dose shape. But if you look back here, because the rectum's in that area, you can actually see a little bit of a carve out here for the rectal dose. And so again, we're allowed to actually target tumors to a higher dose, but keeping other organs at a lower dose with this technique. Here's just another depiction of what can happen for a head and neck patient. So this is with an IMRT approach, and each of these different slides here is supposed to look at that dose distribution from that beam angle. Another type of radiation therapy that we have is called volumetric modulated arc therapy. We call it VMAT, and this is basically a way to deliver IMRT, but in a 360 degree arc around the patient. And so what happens with this is actually the treatment machine is moving the entire time it's delivering the radiation beam. And this allows for a quicker treatment delivery for patients and actually a more conformal dose of the prescription for patients, as well as improved what we call dose homogeneity, meaning at that level we're treating and targeting, the dose looks the same across that whole area. We don't have hot spots or cold spots. But the cost of this therapy is that there can be a little bit more low dose of radiation to some of the surrounding tissues. So this is just an example here of one of our patients where we see this is actually an IMRT plan on the left, and then what we call a VMAT plan on the right. And what you can see is that the high dose area, which is in red, is pretty similar to both across both of these images. However, if we look at these moderate doses in the greens and the blues, they're a little bit more conformally shaped in the VMAT plan compared to our IMRT plan. Another type of radiation that we utilize is called brachytherapy. And what this is where we place a radiation source inside or adjacent to a tumor. This allows for rapid dose fall off and maximal sparing of normal tissues. And so basically when we give brachytherapy, because we're putting the radiation inside of the tumor or a body cavity, we don't have to go in from the outside through some of our normal tissue. And this is commonly used for tumors of the GYN origin, like cervical cancers, endometrial cancers, vaginal cancers, some head and neck cancers like nasopharyngeal cancers, as well as other types of tumors that are close to body surfaces, so prostate cancer, sarcomas, and tongue, lip, and breast cancers as well. This is one example of for eye tumors, so ocular melanomas. We can actually put a little plaque, and this is what a dose distribution can look like from this. So this would be actually simulating the lens, the retina back here, and this is where that tumor was located. And we can see that we can get a very nice dose of radiation to the tumor and no dose of radiation out to the other part of the eye. This is an example of a cervical cancer where a patient, this is what we call a tandem and ring apparatus. So this straight piece here goes into the cervix and the uterus. This circular piece here actually sits inside the vagina but touching the outer portion of the cervix. And this is what it looks like on a CT scan. And these different isodose lines represent different levels of radiation, but we get a very high dose of radiation to the tumor, the uterus, and the cervix, and minimal dose of radiation elsewhere. Another form of radiation that people may be familiar with is called stereotactic radiosurgery. This was historically used to treat brain tumors, and kind of the machine name that people hear about is called gamma knife. And then this technology was so successful in the brain that we've developed ways to do this in other parts of the body, which we now call SBRT, or stereotactic body radiation therapy. And so the top right picture here is a picture of a gamma knife plan, and then the bottom right picture here would actually be lung SBRT. And this is has been so successful now that we use it to treat lung tumors, liver tumors, bone tumors. And it's been so successful in lung cancer, actually, that there's now a randomized study that's open comparing this therapy to actually surgical resection because it's been that successful. One of the points I always like to make is many people have heard about CyberKnife. So CyberKnife is a type of machine that actually delivers stereotactic radiosurgery. So I kind of, when I teach my residents, I tell them it's kind of like a brand name versus the generic name. So CyberKnife is just a brand name of a machine that does that. So now if we talk a little bit about radiation biology, so this is what a classic radiation survival curve would look like for a tumor. And so what this picture shows, so this line here with the kind of square dots would be if we used sparsely ionizing X-rays or photons. The dark line here simulates a different type of radiation like neutrons or alpha rays. And you can see this is what a cell survival curve would look like if we gave a single dose of varying doses of radiation therapy. So if we gave a single dose, the higher the dose we give, the more cell kill that we have. But what you can clearly see here is there is a difference between different types of radiation particles in the response of tumor. There's also an effect of fractionation, so it's pretty rare that we actually give a single dose of radiation. And so what we can see here is if we actually fractionate radiation, which leads to improved toxicities for patients, this is the type of curve that we would see here. So this is the same cell lines with a single dose of radiation and then a fractionated radiation course. But what we can clearly see from fractionation is that we have to increase the dose over time to get the same level of cell kill. And the rationale of this is really that we want to take advantage of improved survival of normal tissues using smaller doses, which we then amplify over numerous treatments. And so this is a curve here looking at how late responding tissues respond and how tumor and early responding tissues look when we compare dose to surviving fraction. Excuse me. When it comes to radiation biology, we talk about the 4 R's of fractionated radiation, which are repair, reassortment or redistribution, reoxygenation, and repopulation. So when we talk about repair, so healthy cells are actually able to repair DNA damage, although some tumor cells can also do that in real time as well. When we look at reassortment, so we know that radiation actually causes cells to accumulate in certain phases of the cell cycle, and certain phases of the cell cycle are actually more susceptible to radiation damage. And so we actually exploit that with a variety of other techniques, which I'll talk about in a little bit as well. We also know that tumors reoxygenate after radiation therapy, which allows for DNA repair, and so that's something that we sometimes try to harness. And then there's also repopulation, and that tumor and normal cells can repopulate between doses of radiation therapy, and so different tumors actually can respond to different dose and fractionations due to their baseline repopulation that can occur. When we look at repair, so DNA is the primary target of radiation, and there can actually really be a couple different ways that radiation targets or the radiation effect can happen at the cell level. So there's an indirect effect where basically a photon or gamma ray comes in and it kicks an electron off, causes a free radical, and then that free radical can go in and damage DNA that's sitting right next to it. And then there's also a direct effect of radiation where a particle can actually come in and directly damage the DNA. And when we talk about direct damage of DNA, there can be things called single-strand breaks, which are certainly very easy for your body to repair because the contralateral DNA template is present. But double-strand breaks are really the best way to damage DNA from radiation and the most effective. And so that's actually we want to try and get as many double-strand breaks as possible. But cells that can correct their DNA double-strand break, they go on to live another day and ultimately repair themselves. One of the other things I wanted to point out, and which is depicted in this picture, is that photons, because they're smaller, cause a little bit less damage than particles when we talk about DNA double-strand breaks. And so that's where we're getting this growing and increasing interest in different types of particles like protons as well as carbon ions. When we talk about redistribution, as I mentioned, sometimes when we give radiation, it causes cells to accumulate in different phases of the cell cycle. So again, here's our cell cycle circle here. And so what we also know is that DNA damage from radiation is most effective in certain phases like the G2 phase and the mitotic phase. But we have checkpoints here, as we know, the G1 and G2, and this is actually one of the targets of some of our drugs now called checkpoint inhibitors, which actually when we give in combination with radiation can allow the radiation to be more effective. So radiation, again, can induce cell cycle arrest to repair the DNA damage. Again, as I mentioned, there's different phases are more sensitive. And so again, here you can see the different phases of the cell cycle. So again, the M and G2 phase are most sensitive to radiation, whereas our LS phase is least sensitive. When we look at reoxygenation, again, we know that radiation causes these free radicals, which help us induce DNA damage. And so we actually know that tumors that are more hypoxic are less responsive to radiation than tumors that are more hypoxic. So sometimes there's additional drugs that we give patients or additional things that we do to improve oxygenation and thereby help improve the radiation response. So these curves here look at hypoxic tumors versus aerated tumors, and we can certainly see that aerated tumors have a higher cell kill with radiation than hypoxic tumors. And so this has actually been a target of various drug investigations to help improve tumor oxygenation. As I mentioned, this kind of leads to the concept of radiation modifiers or radiosensitizers. So what we're generally trying to look at is that here's our normal curve here, where let's just say, for example, we gave 60 gray of radiation, which is simulated by this dotted line here, and we look at our tumor curve and our normal tissue curve, and we would say, okay, well, if I gave 60 gray in this specific example, that leads to 65% local control of the tumor and about 15% normal tissue damage. But generally what we're always trying to do is trying to give that same dose of radiation, but result in higher local control with either the same normal tissue damage or less. And so this is an example of a radiosensitizer. So some examples of radiosensitizers that we use in the clinic are certain chemotherapeutic agents. So it's very safe to add some of those into radiation. One of the most common ones we add in is capecitabine, or the trade name is Elota. So we often will do that to give radiosensitization for patients. Similarly, the other concept that we can look at is radioprotection. So can we actually give a higher dose of radiation, which would result in a higher local control, but actually decrease our normal tissue damage? And so this is also an area of active research. at looking at different ways that we can actually protect our normal tissues, allowing for dose escalation. So some of the examples of radiation targets, and some of these might be talked about in some of your other lectures. So these can be grouped into single target agents, multi-target agents, and then radiation inducible agents. So some examples of single target agents are things that target the EGFR receptor, the VEGF receptor, some of the DNA repair proteins like RAD51, transcription factors. Obviously, we all know about P53, and some of the signal transduction proteins. So there's certain drugs now targeting the PI3 kinase inhibitor, or PI3 kinase inhibitors and so forth. When we look at multi-target inhibition, looking at targeting chaperone proteins, the microenvironment through angiogenesis and vasculature, and then epigenetic modification, and then even some of the radiation-inducible targets, antigens or receptors such as the Fas ligand and CEA. Again, here's just one example of the EGFR family. And so what this depicts is actually some of the different drugs that are out there now. Many of these are on the market, which target various aspects of the EGFR family. So for example, trastuzumab and pertuzumab are used to target breast cancers that are HER2/neu positive. Bevacizumab is a common drug that's used for different brain tumors. Cetuximab is used in head and neck cancers and other epithelial malignancies. And then things like Iressa and Tarceva are commonly used in some of the non-smoker lung cancers, and you can see from here. So what are some of the issues for target agent development? Well, certainly we always have to think about the mechanism. Is this going to be cell type specific, or is it going to be condition specific? We have to look at the method of targeting. Are we going to use an antibody, a small molecule, or gene therapy? And then again, we certainly have to look at the therapeutic ratio. So are we going to affect just tumor cells or just our normal cells or both? And oftentimes, if something's actually affecting both, it may not actually be a good agent for development. So one of the most common things now that we're looking at are some of these immunomodulatory agents. I'm sure all of us see many of these drugs advertised on TV every day. And one of the things that could be really interesting for us as radiation oncologists is that these actually are combined very well with radiation therapy, and they induce what's called an abscopal effect, where basically if a patient is actually getting an immunomodulatory agent and we target one area with radiation, it can actually induce a response to all of their lesions that we can see on CT imaging. So there's actually, this is kind of the seminal paper that was published on this concept in the New England Journal in 2012. And so this was a patient who had a melanoma who received the drug called ipilimumab. And this agent, or this area was targeted with radiation therapy. And then what you saw is as that was targeted, the lesion up here responded and the lesions down here responded, even though the patient had never, I'm sorry, I had that backwards. So this is the area that was targeted, and you can see the radiation plan here. And then what we saw is that these other two lesions responded very nicely without any additional radiation therapy, and this patient basically went into a perceived remission as a result of this. And so some of the types of agents now that we're looking at are PD-L1 and PD-1 inhibitors, as well as many others. I mean, this is really probably the fastest growing area in oncology at the present time. So now if we switch gears a little bit to radiation therapy in the clinical practice. So again, what are our goals of radiation? The two main things that we think about are cure. So certainly trying to cure cancer, which is localized to one organ or region. And then also one of the other big areas that we think about for radiation therapy is palliating symptoms, especially in patients who have metastases. And believe it or not, actually 50% of our patients fall into this category for palliation. And this, I think, is going to continue to grow as all of our systemic therapies continue to grow. Patients are living longer and longer now with metastatic disease. And we're actually seeing disease patterns and metastases that we've just never seen before because patients never lived that long. So again, if we look at some of the indications for radiation therapy, so if we look at kind of curative conditions, basically we can think about almost all of the solid types of tumors. Radiation therapy usually has a role. For what we call liquid tumors like leukemia and lymphomas, the role of radiation isn't as important, especially at least in leukemias and lymphomas. It's a little bit institution specific. And then we look at palliation. These are just some of the main examples where we use radiation. So bone metastases for bone pain, shortness of breath when tumors are pushing on one of the bronchi, neurologic symptoms if a patient has brain metastases, or if a patient has pain or discomfort from a space-occupying lesion, to name a few. The oncology team is actually a multidisciplinary team, and to be honest, this is, I think, one of the things that draws a lot of people to the oncology field. So again, this is made up of radiation oncology, medical oncology, surgical oncology, There's now interventional radiology oncology fellowships. So this is just continuing to be a growing field. And we certainly work very closely also with our social work and support services and additional other specialties. So when a patient comes in to see us, one of the main things is that we do develop a multimodality plan. So it's pretty rare that any one cancer is cured by one therapy. Almost all cancers actually need several different disciplines as part of them. So again, this may include surgery, radiation, systemic therapy like chemotherapy or other targeted agents, as well as other localized therapies. So there's things like RFA, TACE, other focal ablation techniques, and then there's other ways to do focal drug delivery as well, such as isolated limb perfusion. The radiation therapy treatment process, what it involves is first that we see patients in a consultation visit. Once that's completed and we deem the patient to be a candidate for radiation therapy, then they undergo a CT simulation or a planning session for radiation. We then take those images and transfer them to our treatment planning system, and we do have the ability to fuse in outside images like MRs, PET scans, different scans in different positions, or scans with IV contrast. From there, we then actually create the plan, and so what that process entails is one, contouring, and I'll have some pictures of all of these. So we look at contouring out the normal structures as well as our target structures. We then create a plan, and so this is actually done by a whole field called dosimetry. The plan's then evaluated by a doc as well as a medical physicist. That's then transferred to the treatment machine, and then there's the actual treatment delivery. So all in all, that process from kind of a CT simulation to actually treatment delivery takes about a week to a week and a half, depending on exactly the type of radiation therapy that's being delivered. So one of the common questions we get when patients come in, they say, oh, I'm not going to get radiation today. And usually the answer is no, unless it's an emergency, you're not getting it today. You're going to be getting it in a couple of days or about a week. So this is just one example of this is actually our treatment planning system that we have at the University of Maryland. So this is actually one of my head and neck cancer patients. And I just wanted to depict some of the different things that we can actually contour out when we're doing our treatment planning. So this patient had a head and neck cancer and they had surgery. So we see all these bright surgical clips. And so the yellow here and the pink here are my target volumes. So these were the neck lymph nodes that we were targeting. The blue and the green are what we call that PTV, which accounts for patient setup uncertainty. And for head and neck cancers, we actually feel that we have about a 3 millimeter certainty of exactly of where we're targeting. And then what you can easily see here are some of the other organs that we've drawn, the spinal cord, the mandible. This red here is actually what was the postoperative bed for this patient, the parotid glands. And so we can then actually put all of that into the computer, and that helps it create this inverse plan using IMRT or VMAT in this case. So moving on to just some patient presentations. So this first patient here, we'll talk about kind of the different steps that they went through. So this patient is a common scenario, so 55-year-old female who developed a new lump in her left breast. She then had an abnormality. She went to her primary care physician, had a mammogram ordered, which showed a suspicious abnormality on that mammogram. A biopsy was performed of that lesion, which showed an infiltrating ductal carcinoma, which is the most common type of breast cancer. And then importantly, this patient had no family history of breast cancer, which is certainly something that we always ask all our patients about their family history. So this patient comes in, and then we have to discuss her treatment options. So some of her treatment options may include a mastectomy, which you can see kind of one of the old Halsted mastectomies here, or breast conserving therapy, which could include a lumpectomy and radiation. And so these are some of the different types of surgery a patient can have. A radical mastectomy, where they remove the entire breast and the muscle, which is what this depicts. A modified radical mastectomy, which is really the type of mastectomy that's commonly performed today, where we just remove the breast tissue but leave the muscles intact. And then a lumpectomy, where we actually just remove the tumor and a little bit of tissue around it, and patients have the advantage of being able to keep the breast and maintain their cosmesis. So this patient in this example, after kind of hearing all the pros and cons of both approaches, opts to select for breast conservation. So they have a lumpectomy performed as well as a sentinel lymph node biopsy. And in this example, the pathology revealed a 3-centimeter tumor as well as 4 axillary lymph nodes that were positive for disease. So the patient then goes on to receive their chemotherapy, and then they come in to see us as radiation oncology. So when we're looking in this scenario, we have to first think about, well, what type of radiation modality do we want to use and what do we want to target? So there's a couple different ways we can use external beam radiation therapy. So one is with protons, one is with photons, and one is with electrons. We then talk about, is brachytherapy an option for this patient? So there's different types of brachytherapy again, sealed sources or unsealed sources. This is an example of a type of brachytherapy called an interstitial brachytherapy because we put these interstitial catheters in. To be honest, this isn't usually done in our country, but done in some other countries. And then the radiation is actually delivered through these catheters. We then have to identify the target in our normal tissue by undergoing that CT simulation. So this is actually an example of a CT image obtained of a breast cancer patient with a left-sided breast cancer. So you can see the images here, and then we create some beams, which are actually depicted here in these colors. So this yellow here would be a beam, which we call in this example a supraclavicular field. You can see that here. And then the purple here, which you can see here, would be what we call the tangent field in this scenario. And then we create a radiation plan. So this is actually the work the dosimetrist would do. And then as a physician, I would come in and review this plan. And we see different isodose lines. So the red is always the 100% isodose line. And then we have variations of that. And what we can see is that we get a nice dose of radiation to the breast tissue and minimal dose of radiation to the heart here and the lung here. We would then deliver the treatment. And so when we're actually delivering the treatment, one of the things that we do first is certainly line the patient up. So patients have special marks on their bodies, which we actually have a laser basically grid in the room, which we can use to line them up. And then nowadays, we also have the ability to do what's called image-guided radiation therapy, which you can see here, where we basically take an X-ray of the patient before we actually deliver their treatment to make sure that we know the exact location of what we're treating, and we can make millimeter and incremental shifts if needed. So a second example of a patient here is a patient B. So this is a prostate cancer case, so a 54-year-old male who has an elevated PSA on their routine screening, no history of prior medical problems, and then they have a biopsy performed, which is consistent with an adenocarcinoma of the prostate with what's called a Gleason score of 6, which is kind of the low-risk version of prostate cancer. So again, if we think about developing a treatment plan, we have to think about, well, hey, this patient actually has a lot of different options. They can undergo surgery. They might need surgery and radiation based on surgical findings. They could actually undergo radiation alone, but this patient would actually have an option of brachytherapy or external beam radiation or potentially a combination of both. Or they could get radiation and hormonal therapy. This is an example of a brachytherapy plan of prostate seed. So I think many people have heard of prostate seed implants. So this was one of my patients. And so what is drawn out here that I'm circling is actually, this is the prostate as seen on a transrectal ultrasound. So the ultrasound probe is here in the rectum, and this is actually some of the rectal tissue. And then this is actually the prostate that's kind of in dark gray. And then we actually, all these green dots actually simulate a radiation seed. And so we can actually get a very high dose of radiation to the entire prostate, minimal dose of radiation to the surrounding tissues. And we have the ability, with the reason we see a little gap here, is that this is where the urethra is that I'm circling. And so we're actually able to keep the radiation dose away from the urethra, but still give the radiation to the entire prostate. Again, this is an example of a prostate cancer patient undergoing external radiation through a VMAT technique. And so the red here is the prostate, the blue here is that CTV and PTV margin, and then we can actually see that there's a very nice conformal dose distribution just to the prostate. This is actually the bladder here, which we can see, and then the rectal tissue, and we can see that the radiation carves nicely around both of those. As I mentioned, we have image-guided radiation therapy, and so another way we can do that, especially for prostate cancer patients, is through gold markers or a Calypso system. So this is an example of a Calypso system. So basically what happens with that is that our urologists actually can place 3 radiofrequency beacons directly into the prostate, and then we as radiation oncologists can actually triangulate the exact location of those beacons each day and actually during the treatment. The reason that's important is that as men are having their prostate cancer treatment, the bladder can be filling, and then the rectum can fill, or a patient can pass gas on the treatment table. And what's actually been found is that the prostate can move up to 1 to 2 centimeters in any given direction, kind of at any given moment in time. And so this Calypso system actually allows to track the prostate in real time and stop the radiation if we see a certain motion. This is an example of a patient with gold fiducial markers in. So we put these into the prostate the same way we do those Calypso beacons. And then what we can actually do each day is triangulate those beacons with a pretty high certainty. So this is an example of a patient. This image here was created actually from their planning session at the time of their planning CT. And then this image here on the right was actually taken right before their treatment was delivered. and we can rotate the patient and move the patient, but what you can see is that the shape of these beacons or fiducials is exactly the same for both of those. And then the other thing we have the ability to do on our radiation treatment machines now is what's called a cone beam CT, where we actually can take a mini CAT scan of the patient before we deliver the treatment, and we can make adjustments based on that. So in this example of a prostate cancer patient, what's important about that is we actually want to see, is that patient's bladder the same fullness today as it was the day of their planning session? And that can be important if we're treating the lymph node regions, because the bladder can actually help push the bowel out of the way. And so what you can actually see from this picture on the right here, so it's hard to see it, but so up top here where I'm moving my cursor, this is actually the image from the planning session. And then there's actually a red box here with red kind of corners on the end. This is actually what it looks like today during that treatment. And so the yellow line here for the bladder was how big it was the day of the planning session. But what we can see here right now is that this bladder isn't as full as the day of the planning session. And so this example, we actually have the patient get off the table, drink some more water, fill their bladder more, and then we can make sure we're giving them their very precise treatment that we planned at the time of their planning session. And then again, certainly delivering the treatment. So jokingly we say, is it all just that easy? Well, of course it's not. So we have to talk about other things like normal tissue toxicity and managing side effects. So there can be acute or short-term side effects that patients experience during the radiation, as well as late and long-term side effects. So when it comes to acute side effects, what we always tell patients are kind of two things. So one, radiation only affects the area we're aiming the beam at. So I always joke around, if I'm treating a breast cancer patient and they start to have diarrhea, it's not for me because I'm not getting any radiation to their GI tract. The other thing about radiation is the side effects during treatment are cumulative. At the beginning, they don't have any. As they go throughout the treatment, they develop, and then once the treatment's done, they taper off again. So actually, for most patients, the worst time for radiation is actually the week after, because they've actually received all the dose. And so some of the side effects actually can get a little bit worse for 3 to 4 days afterwards. And so it's always very important for us as clinicians to make sure we counsel our patients on that, because it's pretty frequent that you'll get a call and patients will say, it's getting worse, I don't know what to do, should I go to the hospital? And we have to reassure them, no, this is exactly what we expect because of how radiation therapy works. When we talk about late effects, we generally define these as things that occur 90 days after completion of radiation. So there's a set series of late side effects that, depending on which part of the body we're treating, we do have to monitor for. So for example, for lung cancer patients, we have to monitor after treatment for something called radiation pneumonitis, which can be inflammation of the lung as it's healing from the treatment. In addition to that, we have to think about things like stem cell depletion, chronic oxidative damage, vascular destruction, fibrosis, and more. And these are generally things that account for some of these late side effects that patients can experience. But again, one of the things that's really important to hear is that radiation isn't actually dosed to the, or radiation is actually dosed to the normal tissue and not the tumor. I could kill every tumor if I could give it 100 or 200 gray. That wouldn't be a problem. But again, our normal tissues actually can't tolerate that. So what we're always doing in radiation oncology is trying to figure out how much normal or how much radiation can those normal organs right next to this area tolerate and how much can it. And that ultimately, at the end of the day, really defines how much dose our tumor gets. So as I mentioned, one of the things that can happen in the long term is lung fibrosis. So this is actually the pathway by which this is thought to happen, although now this is an older schema. Certainly now there's probably 10 more arrows to add to this. But we know when patients get radiation, they activate TGF-beta, and that this has actually been responsible for patients getting radiation pneumonitis and even radiation fibrosis. So this is an example of a really, really old way we used to deliver radiation. And just to point out, the date on here says 1992. This is not how we would deliver radiation anymore. But this was the shape of the beam. And what you can see here, this is a corresponding CT image for a patient who has lung fibrosis. And you can actually see exactly where that beam went. Okay, it went front to back, and one edge was here and one edge was here. For breast cancer, something that we often have to think about is lymphedema. So the great news is that lymphedema is becoming a little bit less common now as our surgical techniques have improved, as we've added in neoadjuvant chemo or chemotherapy before surgery. But this still is a problem that some women do experience. And sometimes it's because the tumor damaged their lymphatics. Sometimes it's also part of the treatment, both the surgery and the radiation. And so what can happen when it comes to radiation is that radiation, so again, this kind of, here's it's all about kind of pressures. So high pressure, low pressure, and you can see kind of how the blood flows through this area. But what can happen is radiation can actually affect the expansion and contraction of our various blood vessels, can cause a little bit of fibrosis, which leads to pressure changes, and that's actually how the lymphedema begins to happen. Mucositis is a common side effect for head and neck cancers, but really a cancer that involves any mucosal surface. So this can actually happen for esophageal cancers, rectal cancers, vaginal cancers, and so forth. And basically what happens is the same sunburn effect patients can get on their skin, they can get on the mucosal surfaces. And what this is ultimately a result of is some stem cell depletion to this area. Now, believe it or not, this actually recovers within about 2 weeks after patients finish, because your body's actually able to heal very quickly from this as long as there's good nutrition involved. But this is actually one of the main side effects that our head and neck cancer patients experience, and the one that we actually are managing the most for these patients. This certainly, as it looks like, can be painful for patients. It affects their eating, it affects their taste buds, and all those types of things. So where do we go from here? So some of the future of radiation. So again, when it comes to radiation biology, I think we're constantly searching for different ways to use radiation to induce targets for other agents. So actually also using radiation as a sensitizer, maybe for chemotherapy. We have some studies ongoing at our institution looking at that. We're constantly looking for better radiation sensitizers and protectors. So one of the therapies that we have at our institution is also hyperthermia, which is basically heat therapy. And so what that actually does is improves blood flow, improves oxygenation, and actually improves the effect of radiation if we give it within a certain time frame of radiation. And we're also looking at combining radiation and other targeted agents, and I think this will continue to be an ongoing thing. From a physics viewpoint, we're always looking at improving our targeting as well as our imaging on the treatment table, as well as improving our delivery methods and equipment. So at our institution, as well as many others around here, there's new radiation therapy modalities such as proton therapy and so forth that are all looking at improving the delivery of radiation. And then from a clinical viewpoint, we're always looking to translate our exciting laboratory findings into the clinic. So certainly we have a variety of phase 1 studies, as many academic institutions do, and continuing to develop our clinician scientists. But one of the, again, the most exciting things is really looking at the synergy that we can have with the immunotherapy agents, especially because these are so well tolerated for many patients. So one slide I wanted to talk about with proton therapy. So proton therapy is a little bit of a different form of radiation. Again, it's actually a particle as opposed to an X-ray. And basically the difference between the two can be summarized in this picture here. So with our X-ray radiation or photon radiation, this is what that curve looks like in the body. So it starts off in the body a little bit weaker. It gets strong a couple centimeters into the tumor, and we can vary this based on the energy of the photon. And then it gets weaker and weaker and weaker and weaker as it passes through. But X-rays have what we call this tail, where it just gets weaker and weaker. Proton therapy works a little bit different in the body in that it starts off in the body a little bit weaker than photons. We actually don't worry about this too much. It gets strong where we tell it to, right in the tumor, and then it stops, and it has the shape, and this is called what we call the Bragg peak. And so what this can mean for our patients is that we can actually avoid this whole area here. And what's in this area are these incidental normal tissues that are getting radiation that don't really need it. So for breast cancer, which is what I focus on a lot, this can mean I can almost completely avoid radiation dose to women's heart. I can often avoid dose to their lung. For CNS tumors, it can mean sometimes I can avoid complete dose to the brainstem or the optic chiasm or the cochlea and so forth. This is just one example of one of our patients using proton therapy as well as photon therapy for a breast cancer patient. And so again, you can kind of see the shape of the red's about the same, not too much different. But when we look at, again, these low and moderate doses of radiation in the yellow and the green, this here is the heart in the middle, and we can see that with photon therapy, this is kind of the best plan we can get, where we're still kind of bathing most of the heart in this green dose. And with proton therapy, you don't see that at all. The other thing that is probably hard to see is that there's actually these little gray circles here, which are actually where the coronary arteries lie. And so we can actually avoid those almost completely with our proton radiation. And so here's actually a subtraction image of what that looks like. And what we know, and why this might be important for breast cancer patients, for example, is that we know there's been 3 big studies published in the last couple years showing that the lower dose of radiation to the heart we can get, the less heart side effects women have down the line, like heart attacks, heart failure, valve problems, all those things that can happen to women down the line. So the lower we get that, the better. So again, proton therapy can be a tool to do that in this example. We have a proton center up in Baltimore, right next to the hospital, called the Maryland Proton Treatment Center. And the model we've developed at that institution is really that we're a resource to a lot of other providers in the area. So we've actually partnered with institutions like Georgetown, Inova Fairfax, some groups in Pennsylvania, where they actually bring their patients from their communities and treat them at our center so that all their patients have access to the best modality. We have 5 treatment rooms and a unique throughput process to treat about 150 to 190 patients per day. We're not there yet, but we're usually around 100 now. So overall, some take-home messages. So radiation is a tool used in cancer therapy. It works by causing DNA damage, which can ultimately lead to cell death. The effects of radiation can be altered by a variety of different factors, such as physical factors, physiologic factors, fractionation, drugs, and a lot of other variables. And we're constantly looking at ways to improve these interactions and give our patients the best benefit. Certainly, radiation can cause complications. And then lastly, radiation is interesting. So any questions? Yeah. Sure. You said inappropriate? Yeah. Okay. And then second, you mentioned patient A example. There's a particular method that you use outside the US but not in the US. I wonder what's driving. Sure. Yeah, so good question. So for the online people, one of the questions was, which patients are inappropriate candidates for radiation? So there are patients that we don't want to give radiation to, or we try to avoid it. So certainly one of the main factors is children. So we know that radiation actually has the potential to induce a cancer down the line. Now that risk is rare. It's about 1 in 10 to 20,000 patients, and it's not a risk at that moment in time. It's a risk 10, 20 years from now. But certainly when we think about pediatric tumors, we're actually always looking at ways to either decrease the dose of radiation that we need to deliver or potentially try to avoid radiation in certain cancers. And so even if we look at the history of a lot of the pediatric malignancies over the last, say, 10, 20 years, some of them have removed radiation, which it's a good thing for patients. Certainly we can't give radiation to pregnant women because a fetus is very susceptible to radiation damage. So if we do have someone who has a pregnancy, that would be a contraindication to radiation. And then there are some relative contraindications to radiation. So there's certain connective tissue diseases, like scleroderma is the big one, where those patients already are at risk for a lot of fibrosis in their body in general. And radiation, since it can induce fibrosis, that's a condition that we often will try to think twice and maybe try to develop a treatment plan that maybe doesn't involve radiation first and only give radiation maybe if treatment plan A doesn't work. Some of the other diseases like rheumatoid arthritis and other connective tissue diseases, we're finding that it's probably really okay, especially now with our newer techniques of radiation to deliver. Another relative contraindication is that we always, if a patient has received radiation at that body site once already, it's again something we need to think twice about because those normal organs might not be able to tolerate additional radiation without getting permanent damage, for example, the spinal cord. Now, I say it's relative because a lot of things go into that. So even when patients come to see me, I say the book answer is no, but a lot of times we safely can give extra radiation using different techniques like maybe proton therapy or maybe giving it twice a day instead of once a day and so forth. So those are just some examples. But yeah, so we don't just offer it to everyone, but there are some contraindications. And the last one that might be relevant, I think, for this group is that there are certain genetic conditions where we try to avoid it, specifically things like ataxia telangiectasia. We try to avoid it in Lee Fromeni. I know there's a clinic here. We always try to minimize radiation in those patients because we know that they're at a very high risk of developing a radiation-induced malignancy. And then your second question, I forget now, was? Oh, yeah. So in the patient A example, the interstitial brachytherapy picture I showed, so part of the reason it's just not in favor as much, we can do it here in the US, but it's just not kind of the favored treatment. One, because as the picture looks, it can be a little morbid for patients to They actually have those catheters in the breast in that example for like a week or 2 weeks. So it can be difficult for patients to kind of walk around with that and so forth. Also, it does take a higher skill set and some special machinery for a radiation oncology facility to have that. And so a lot of centers, especially smaller ones, opt not to invest in those technologies, and that if they do have a patient who needs that, they would send them to one of the universities like us or Hopkins or Georgetown or something like that. So as a result of that, it's just kind of, it's a little bit of a dying art where fewer and fewer people are doing it and getting exposed. But the converse of that is we have other therapies that have taken their, its place that have the same outcomes. Go ahead. Mm-hmm. Right. Yep. Yeah. Sure. Yeah. So the question kind of focuses on the examples prostate cancer patients where there's a push to having radiation oncology involved and consulted up front before patients decide on their treatment. So this is actually still a big issue in our country too. And so part of it, if we just take the prostate cancer example, so the way prostate cancer is diagnosed is by a urologist doing the biopsy. And so the urologist is the one that will often give the patient the results. And then they're that first step into kind of the opening the door to the cancer discussion. And so they talk about the different modalities, and certainly as a surgeon, they know surgery best. So there has been a movement in the U.S. as well, and I think many countries that have the resources where it is actually very highly recommended by like our radiation oncology societies and even by the urologic societies that when a patient, for example, with prostate cancer gets a new diagnosis, they should meet with a radiation oncologist to at least hear what their options are. Because, I can't counsel a patient on all the ins and outs of surgery, they can't counsel a patient on all the ins and outs of radiation oncology. So a lot of metropolitan areas like this, there are cancer programs built together where there are groups that work together all the time. So like we have certainly urologic surgeons, radiation oncologists, medical oncologists, all the different specialties. And so what a lot of places do are what are called multidisciplinary conferences, where once a week we all get together and we talk about the new cases, we talk about the different treatment options for that patient, and we usually come up with a consensus recommendation. This is what we think would be best for you, or these two are equal. Here's the pros and cons of each. You and your family need to decide what's best. I think though in the rest of the country, which is, to be honest, the majority of the country, those resources don't exist. And so it certainly is a bigger problem where, I hear it still, even in this area sometimes all the time, like, oh, well, they never told me I could get radiation, or they never told me to meet with a radiation oncologist and now my cancer's back. So it certainly does happen, and there certainly is room for improvement in our country as well. But again, it then goes to the bigger picture, I think, of overall healthcare issues, insurance issues, all those types of things. Go ahead.
When we were talking about reoxygenation of tumors, I think you said that tumors respond better to radiation therapy with more oxygenation. What's the explanation?
So the question is about why do tumors respond better with more oxygenation? So when there's more oxygen in the tissues, oxygen can be a free radical. And so what happens is the radiation comes in, kicks off that electron, creates a free radical. And then if that oxygen molecule is sitting next to DNA, it can go in and cause indirect damage. So that's basically how that works. And that's actually how the majority of radiation damage works with photons, at least. That's our biggest effect. For that reason, though, that's also why we often counsel patients not to take a lot of antioxidants, because there's the hypothesis that it will actually reduce that ratio. So, all right, well, that was our last question. Thank you all so much.
Our last speaker for today is Jim Kochenderfer. He's with the Experimental Transplant and Immunology branch, headed by Ron Gress. He got his MD from West Virginia. He did his residency at Vanderbilt in internal medicine, and then he did a hematology and oncology fellowship at MD Anderson in Baylor. And he's been here for about a dozen years. And his title, Chimeric Antigen Receptor T-cell Therapy for Lymphoma and Multiple Myeloma. Jim.
Okay. All right. Thank you very much, Terry, for inviting me, and I'll go ahead and get started. So I've been working on just CAR T cells and nothing else since 2007. First, I did 2 postdocs here. One was Ron Grass and one was Steven Rosenberg, and then after that I was an assistant clinical investigator in a clinical investigator development program. So, and then now I'm a tenure track investigator. So I've just been working on this for quite a while. So the first part of the talk is going to be about lymphoma, treatment of lymphoma with anti-CD19 CAR T cells. Is the sound okay? Can everybody hear? So this one's not working. It's right here. So, no. Okay, is that better?
That's not too. This one works better.
Okay, all right. All right, thanks. So lymphoma first, we'll go ahead and get started. So for those that are not familiar with CAR T cells, a chimeric antigen receptor, or CAR, is a fusion protein that contains an antigen recognition moiety, which is usually derived from a monoclonal antibody, which we see in this part. You can't really see the laser though, can you? So after the antigen recognition moiety, we have the hinge and transmembrane domain. That's better, which is here. And then there's almost always a co-stimulatory domain, such as CD28 or 4-1BB. And then a T-cell activation domain, which is almost always CD3 zeta. This fusion protein is encoded by DNA. The DNA is put into some type of vector, such as a lentivirus or a gamma retrovirus. And this vector is used to transduce T cells. When the T cells are transduced, the DNA becomes a permanent part of the DNA of the T cell. And the CAR is then expressed on the T cell surface, which gives the T cell the ability to recognize a tumor antigen, in this case CD19. So when I started out in Steven Rosenberg's lab as a postdoc, we were working on CD19, and I made this CAR in 2007. We published the results in 2009. It is a CAR that has the single-chain FV derived from the FMC63 anti-CD19 monoclonal antibody. That's a murine monoclonal antibody. Then it has a hinge, transmembrane, and co-stimulatory domain, all from CD28. And then it has a CD3 zeta T-cell activation domain. The way we produce cells, which is one of the secrets of, I think, success for surgery branch at the NCI, is it's a very simple cell production process. Whole PBMC are stimulated with an anti-CD3 monoclonal antibody called OKT3, and the cells are just grown in culture with IL-2 in an incubator. And then once the cells are in culture for 7 to 10 days, they're ready to infuse. And it's a very simple, robust cell production process. So the T cells expressing this CAR recognize CD19 with great specificity in vitro assays. So I don't really have slides to show that. I'm going to go on to one of the earlier clinical trials that we did, one of the earlier cohorts on the trial. In this trial, we used fairly high doses of chemotherapy followed by an infusion of CAR T cells. So the cyclophosphamide and fludarabine, those were the 2 chemotherapy agents we used. Cyclophosphamide at a dose of 60 to 120 milligrams per kilogram of total dose, and fludarabine 25 milligrams per meter squared daily for 5 days. So the cyclophosphamide was given on days -7 and -6, and fludarabine on days -5 through -1, and then the CAR T cell infusion on day 0. This is an example of one of the patients we treated. This patient had chemotherapy refractory primary mediastinal B-cell lymphoma, which was one of the many types of large B-cell lymphomas. It had recurred after 4 prior lines of treatment. The patient has an ongoing complete remission, which is now actually 70 months long. This says 56. I need to update this slide. But you can see here this yellow-orange circular shape, that is metabolically active lymphoma. And this round mass in her chest is all lymphoma. The middle part of it is necrotic. That's why it's not lighting up. This mass was present despite 4 prior lines of therapy, including radiation therapy. 23 months later, we did another scan, and this mass was completely gone. This was after the 23 months after the CAR T-cell treatment. So just to kind of summarize this part of the talk, what we did, we had 7 evaluable patients with diffuse large B-cell lymphomas. 5 out of 7 patients obtained complete remissions, and 4 of these complete remissions have had very long durations of remissions of 70, 67, 38, and 48 months. So these are the patients in the whole world that, with diffuse large B-cell lymphoma that have the longest follow-up. So that's one reason why they're interesting, and the other reason is that they've had these complete remissions that lasted a long time. None of these patients had lymphoma relapse. This was all published in Molecular Therapy in 2017. So in more detail, these patients had these types of lymphoma. So primary mediastinal B-cell lymphoma, if you're not a hematologist, you may have not heard of that before, but it's just one type of diffuse large B-cell lymphoma. So 2 of the patients had that, and 2 of them had what we call diffuse large B-cell lymphoma not otherwise specified. I already mentioned their duration of responses, which is very impressive. These patients are living, well, 3 of them are basically living normal lives, completely free of lymphoma for all these months, 70, 67, and 48. Patient 8 was lymphoma-free for 38 months and continued to be lymphoma-free, but unfortunately she developed another disorder called myelodysplastic syndrome, which is a disorder of bone marrow, which is generally known to be caused by chemotherapy. She had a ton of chemotherapy before she got CAR T-cells, so she developed this myelodysplastic syndrome and had to get an allogeneic stem cell transplant, which is the treatment for myelodysplastic syndrome. So that happened 39 months after her CAR T-cell treatment, so we can't really evaluate her response after 38 months because she had the allogeneic stem cell transplant. In this column, I have the months after infusion that CAR T-cells were still detectable in the patient's blood. So patients 2 and 7 had fairly short durations of T-cell detectability. Patient 2 only 5 months, patient 7 4 months. Patient 8 still had a very low level of her PBMC that had CAR T-cells detectable at 39 months at 0.08%. And patient 15 had a very low level of 0.02% detectable CAR T-cells in the PBMC at 43 months after infusion. So the way we detect the CAR T-cells with this is by PCR. We have a quantitative PCR assay that we do because the CAR is an artificial gene. We can easily design primers to detect the CAR, but not any other gene in the human genome. So we can detect this CAR very specifically by PCR. We also have flow cytometry assays, but the PCR is the most sensitive. So for this data here, we use the PCR assay. Note that the level is extremely low. Even though 0.02% were detectable, that's still 0.02% of your PBMC is a very low level of cells. Also, I should mention that patients 2, 7, and 8 had lymphoma that was refractory to chemotherapy, and patient 15 had lymphoma that relapsed after an autologous stem cell transplant. So all these patients had very poor prognoses and very advanced lymphoma. So one of the things in the CAR field that people argue about is the importance of persistence of the CAR T cells. There are 2 main theories. First of all, the CAR T cells can kill all lymphoma cells early on after infusion, so long-term T cell persistence is not important. The other theory is that the CAR T cells cannot eliminate all lymphoma cells, but a fraction of lymphoma cells can be eliminated. In this case, the CAR T cells need to persist to continually suppress lymphoma relapse. Theory 2 requires that the CAR T cells fail to eliminate lymphoma early when the CAR T cell numbers are at their highest, but can effectively suppress lymphoma for years after infusion. So we had a kind of a simple way to assess this, I guess the validity of these 2 different theories. We always measure the recovery of the normal B cells in the patient's blood after we do CAR T cell infusions. So this graph shows the levels of the normal B cells in the patient's blood. These are normal polyclonal CD19 positive B cells. And below in the FACS plots, we show some of the FACS plots. This one shows that the recovering B cells do indeed express CD19. And so here we have the B cell level on the y-axis, the months post-CAR T-cell infusion on the x-axis, and then this dashed line shows what a normal level of B cells is. So the normal level of B cells is about 61, so that's where the dashed line is. So we can see early on after treatment, all 4 of these patients had no detectable B cells in their blood. So that's evidence that the CAR T cells combined with the chemotherapy did eliminate their B cells early on, and even not really early on. It's up to like 8 months after treatment before they even start to recover at all. So usually we know that this chemotherapy, the B cells will recover within 2 to 3 months. So the CAR T cells do eliminate B cells for a time after infusion of the CAR T cells, but then the B cells recovered in 3 out of the 4 patients, all the patients except patient 8. So despite the fact that these normal CD19 positive B cells recovered, these patients stayed in complete remission. So the recovery of the normal B cells shows that there's not really an effective CAR T cell population in this patient, because if there were effective CAR T cells in the patient, they would kill these normal CD19 positive B cells. But the fact that they did not kill the CD19 positive B cells tells us that there's really not a functionally effective CAR T cell population in these patients. And again, these graphs go all the way out to here. The patients have normal CD19 positive B cells, yet their lymphoma did not relapse. All the way out to the end of the graph. So this tells us that the lymphoma was most likely eliminated early on, and then the CAR T cells probably died out and became functionally ineffective. We already showed on the last graph that the CAR T cells were not detectable in the blood by PCR in 2 out of the 4 patients, and the other ones had extremely low levels. But after a time, the lymphoma is eliminated, but the B cells recover. And these are normal B cells, polyclonal as shown by kappa lambda staining, normal phenotype by CD27 and IgD staining. We sometimes give immunoglobulin to the patients to help replace immunoglobulins that are not being produced because the patients lack B cells. So the patients did get some intravenous immunoglobulin replacement here. IgG recovered at least to some degree in 3 out of the 4 patients. IgM was detectable in 3 out of the 4 patients. IgA only recovered in 1 patient. So it seemed like we've seen that in other CAR protocols that IgA seems to be the slowest immunoglobulin to recover. So in summary, some patients with diffuse large B-cell lymphoma obtained long-term complete remissions lasting more than 4 years. Remissions continued after disappearance of functional CAR T cells. Infections have not been a major problem with anti-CD19 CAR T cell therapy. Out of these 4 patients, only 1 hospitalization was required for an infection. So infections have not been a major problem. In an effort to reduce toxicity and simplify treatment, we changed to a low-dose chemotherapy regimen. So now we're getting into more recent work. Again, we're using the same CAR, the FMC6328Z CAR, the same basic cell production process, but we reduced the chemotherapy down to cyclophosphamide 300 to 500 milligrams per meter squared for 3 days, and fludarabine 30 milligrams per meter squared for 3 days. So this is like half to 1/3 of the chemotherapy dose of the previous regimen that I talked about, as far as the cyclophosphamide dose. So again, chemo for 3 days, then 2 days off, then cell infusion. Now, why do we give this chemo at all? We give the chemotherapy before CAR T cell infusions because there's a lot of evidence that shows depleting lymphocytes from mice dramatically enhances the effectiveness of adoptively transferred cells of any type. So this has been shown first by someone named Dr. North, who published papers back in the 1980s, and then more recently by Nick Restifo and Luca Gattinoni in the surgery branch here at NCI. So when lymphocytes are depleted from mice, certain serum cytokines go up dramatically. So when you rapidly reduce lymphocytes, cytokines such as IL-7 and IL-15 go up. And it's thought that this is because the lymphocytes normally need these cytokines to survive and grow. So when all of a sudden there's no T cells there to use up the cytokines levels just continue to be there. There's nothing to use it up, so the cytokine levels go up in the blood. This has also been shown in humans, not so mechanistically as in mice, but almost all adoptively transferred cell products, including CAR T cells, are preceded by chemotherapy because of this effect that's also been seen in humans, that the cells are much more active when you give chemotherapy before the cell infusion. So the purpose of the chemo is really not to treat the lymphoma. This would be very ineffective against lymphoma, but it's to enhance the T cells. So we did this work measuring cytokines in the blood of the patients, 22 patients who we treated on this protocol. And indeed, just like the mice, IL-15 goes up in 22 out of 22 patients. IL-7 went up, and MCP-1 went up. Perforin went down, which is kind of an indication of just eliminating lymphocytes. P was less than 0.001 for all these. Some other cytokines modulated also, but these are the most prominent. So IL-15 is very important for CD8 T cell proliferation and survival and activation. IL-7 is also an important cytokine for T cell survival. So it makes sense that these would help CAR T cells survive. So this is a patient treated with this regimen, patient 35. You can see indicated by the white arrow a large mass of lymphoma in red. This is kidney, and it's supposed to be red, and that's bladder. That's just the dye that's infused with this test. You can see the kidneys here again, and here in the white arrow, the mass was completely gone. So this patient was in complete remission 12 months after treatment with CAR T cells. Another patient with a big red mass here indicating lymphoma. The brain is always red, so that's not a problem. The heart's always red because it's very active and there's a lot of the dye there. And then the kidneys are also red, as I mentioned before. But the important part is indicated by the white arrow here, this big red lymphoma mass here, and also some red lymphoma masses in the abdomen here. 10 months later, it's all gone. Same patient, but different view. So this is a CT scan with a completely different view and a different cut. The yellow area in this one is the lymphoma indicated by the white arrow. 10 months later, it's gone. So this patient was in very bad shape. She had lymphoma that was refractory to 3 common lymphoma regimens, RICE, GDP, and REPOC. Those are all chemotherapy regimens used to treat lymphoma. Her lymphoma progressed when she got those regimens instead of shrinking. So she was in a very bad shape. The CAR T cells put her into this complete remission, and that was in 2015. She's still in complete remission now. The previous patient I showed is also still in complete remission. So the overall results with this regimen were, of 22 patients, the overall response rate was 73%. So to be counted as a response, that means the lymphoma has to shrink by at least 50%. Complete remission, which means a complete disappearance of lymphoma, 55%, and partial remission, which means at least a 50% shrinkage of lymphoma, and 18%. So among these, among the 22 patients, 19 had diffuse large B-cell lymphoma, and 68% of those patients obtained complete remissions. We had 2 patients with follicular lymphoma, and they both obtained complete remissions, and 1 patient with mantle cell lymphoma who also obtained a complete remission. So the most interesting thing about this cohort of patients was the durability of response. So when you talk to patients and physicians, the most important thing is they don't want to just have a response that lasts 3 months. They want to have a response where the lymphoma goes away, they're cured, and they can just forget about lymphoma and go on with their life. So with this, the most impressive thing about CAR T-cell therapy for diffuse large B-cell lymphoma is that the responses are indeed very durable. So we had 12 patients that got complete remissions. 11 of them are still ongoing as far as we know. So here's the follow-up we have. The plus sign indicates the responses are still ongoing. We have 48 months, 19 months, that was the only patient to relapse, 46, 39, 41, 38, 27, 37, and so on months post-treatment where they're still in remission. This patient with a 13-month refused to come back for any further visits to clinic, so we don't know what happened to her after 13 months, but at that point she was still in complete remission. So you can see there's quite a bit of durability, and it was a very successful trial. But there is a downside to CAR T cells, and that's toxicity. So we have fevers in almost every patient, but the most troublesome thing was neurologic toxicity. And the type of neurologic toxicity we saw was things like confusion, dysphagia, which is inability to speak, encephalopathy, which is just basically confusion, drowsiness. It's kind of a catch-all term. Gait disturbances, so difficulty walking. Also, we saw a lot of people with tremors, which was mostly manifested by their hand shaking. Only 4 out of 22 patients had grade 3 or 4 hypotension, which is low blood pressure. The most prominent toxicities were neurologic. Notably, all toxicities completely resolved, usually within 2 weeks. Sometimes it took like a month for things to completely resolve, but usually within 2 weeks, these things went away. So one thing about CAR T-cell toxicity is it can be severe, but it's usually very short. Also, compared to other diseases, it seemed like neurologic toxicity was a more prominent problem for lymphoma patients compared to leukemia patients. So with correlative studies, again, there's a lot of this published in my paper, Journal of Clinical Oncology, Kochenderfer et al., 2017, but just a little bit of the correlative studies. We found an association of peak CAR T-cell levels with response. So patients that obtained a response of complete remission or partial remission had higher levels of blood CAR T-cell levels, again, detected by PCR in this case. And if we look at the neurologic toxicity, the patients that had the severe neurologic toxicity of grade 3 or 4 had higher levels of peak CAR T-cells in their blood compared to patients who had less than grade 3 neurologic toxicity. So the CAR T-cells were associated with both response and toxicity. We also found IL-15 to be a very important cytokine in these patients. You can see these nice high peaks of IL-15 in the patients that had complete remission or partial remission, but only very much lower peaks in patients that had just stable disease or progressive disease. The same thing with IL-10. Patients with high peaks of IL-10 were more likely to have a complete remission or partial remission. And these were significant. So cytokines are also important. IL-15 was found to be the most important cytokine. There's more information about that in the paper. So all this work that I mentioned so far with the FMC6328Z CAR led to multi-center trials and collaborations with pharmaceutical companies. The company which we worked with was Kite Pharma, so we can disclose that, I guess now. I'll disclose that we did have relationships with Kite Pharma with CRADAs, Cooperative Research and Development Agreements. I still have CRADAs with Kite Pharma. So this work led to multi-center trials where the FMC6328Z CAR is now being tested in various clinical trials all around the world, in Asia, Europe, the US. There's at least 8 different trials in the US for different diseases. But one of the big trials was called Zuma-1, and it tested this CAR, which was basically an extension of the work I just showed, the same chemo regimen, the same cell production process. The company treated 101 patients in a multi-center trial. Notably, the manufacturing rate for making the CAR T-cells was 99%. They got an overall response rate of 82%, complete remissions of 54%. So it was very similar results to the results obtained here at the NCI. At 15.4 months of follow-up, the overall response rate was maintained in 42%. CR was maintained in 40%. So 13% of patients had greater than grade 3 CRS. 28% of patients had grade 3 neurologic toxicity. So a little bit lower than we had, but still a significant amount. 43% of these patients received immunosuppressive medications. Mainly 43% received tocilizumab, which is an IL-6 blocker, and 27% received corticosteroids. That's to treat the CAR toxicity. So despite impressive efficacy of anti-CD19 CAR T-cells and FDA approval, much room for improvement remains. For one thing, only 55% of lymphoma patients obtain complete remissions at the NCI, and it's a very similar percentage elsewhere. Neurologic toxicity was a major problem. Published results have also shown that there can be recipient T-cell responses against the murine CAR T-cell protein sequences. So that's another problem, immune responses against the CAR. So current work is aimed at improving on the FMC6328Z CAR. So I guess one way of looking at this is we want to improve the efficacy to toxicity ratio. We hope to reduce toxicity but maintain the efficacy of the treatment. So one of the things we did was use a fully human variable regions instead of the mouse variable regions that we used in the earlier CAR. And we also evaluated how different hinge and transmembrane domains can affect the function of CAR T cells. We hypothesized that a CAR with different hinge and transmembrane domains would provide a different activation stimulus to the T cells and thus affect the functional output of the CAR T cells, such as cytokine production. So here we have a CAR we call Hu19 CD828Z, which has a Hu19 single chain FB as an antigen recognition domain, CD8 hinge and transmembrane domain, CD28 co-stimulatory domain, CD3 zeta T cell activation domain, and we compared that to another CAR called Hu1928Z, which has a Hu19 single chain FB, a CD28 co-stimulatory, extracellular, transmembrane, and cytoplasmic domains. So all these domains come from CD28 and then the CD3 zeta. So this one's very similar to the FMC6328Z. It's basically identical to FMC6328Z, except it has this fully human Hu19 single chain FB instead of the FMC6328 single chain FB. So, the main point of all this is we gave the CARs a human antigen recognition domain to get rid of the mouse protein sequence, and we're comparing these two different hinge regions, one hinge region from CD8 and one hinge region from CD28. So this work has all been published too. So we did extensive in vitro assays and mouse studies. It's published by Leah Alabanza et al. In Molecular Therapy 2017. So some of the work that we did is here. So we think the cytokines are very important because the cytokines are what is thought to cause almost all the toxicity of CAR T cells. So we were looking for a CAR that made lower levels of cytokines, and it turns out that the Hu19 CD828Z with the CD8 hinge and transmembrane domain leads to less cytokine production by the T cells than the Hu1928Z CAR, which has the CD28 hinge and transmembrane domain. So you can see here for interferon gamma, TNF, and IL-2, it's the same pattern. The CAR with the CD8 hinge and transmembrane makes a lot less cytokine than the CAR with the CD28 hinge and transmembrane domains. So we obtained the same results with multiple other, with different CARs and with multiple different target cell lines. So this is done using an ELISA assay where we co-culture together the CAR T cells and the target cells overnight, and then we simply measure the cytokines in the cell supernate with an ELISA assay. I'm not sure how much we want to go into this. This is the activation-induced cell death. We also, T cells undergo activation-induced cell death when they are stimulated with a target antigen that stimulates them too much, basically, and they die. So CAR T cells can undergo this activation-induced cell death, and the CARs with the CD8 hinge and transmembrane basically underwent less. You can see here 20% versus 57% for the CAR with the CD28 hinge and transmembrane domain. And this graph shows that the Hu19 CD828Z CAR had less, statistically significantly less annexin 5 staining, which is a measure of activation, a measure of cell death basically, which in this assay was a measure of activation-induced cell death compared to the Hu1928Z CAR T cells. This is just a further evidence that the CD8 hinge and transmembrane CAR causes a weaker activation stimulus to the T cell, and that's due to the different hinge and transmembrane domains. So despite the weaker activation stimulus, the Hu19 CD828Z CAR T cells can still eliminate tumors from mice. You can see here mouse tumor size. We implanted tumors in immunocompromised mice. So we put human tumor cells in immunocompromised mice and then treat the mice with CAR T cells alone, no other treatment. Because these mice are already immunocompromised, we don't give them any chemo. The tumors form and then the cells are infused on day 0. And then we follow the tumor sizes. You can see that the control groups, which are SP6CD828Z, a control CAR, and the untreated mice both had steady increases in their tumor size, while both groups treated with the CARs, either Hu19 CD828Z or Hu19 CD28Z, had basically stabilization on the average of their tumors, Some mice had complete elimination of their tumors and some mice had tumor growth, so the average was basically a stabilization for a while. Survival, you can see here, there was no statistically significant difference in survival. There was somewhat more mice dying in the Hu19 CD828Z group. And we do think that indeed the Hu19 CD28Z CAR is a little bit more effective in the mice. That's the one that makes the high levels of cytokine. But the difference is very small. And the Hu19 CD828Z can definitely have an anti-tumor effect in mice. So because the Hu19 CD828Z has a much lower cytokine production, and because it can eliminate tumors in mice, although not maybe quite as well as the CD28Z, we decided to do a clinical trial and test Hu19 CD828Z in humans and see what it did as far as toxicity and efficacy. So we put Hu19 CD828Z in a third generation self-inactivating lentiviral vector, which is shown here. This is a vector with the MSCV promoter, which stands for mouse stem cell virus. The Hu19 single chain FV, CD8 hinge and transmembrane domain, CD28 co-stimulatory domain, CD3 zeta T cell activation domain. So again, this is fully human. And we use this vector to modify the patient's T cells, and we infuse the patient's T cells. We use the process that takes 7 to 9 days to make the cells. We gave the patients the same chemotherapy regimen that I mentioned before, 300 milligrams per meter squared of cyclophosphamide, fludarabine at a dose of 30 milligrams per meter squared, both given for 3 days. And then the patients get 2 days off, then they get the CAR T cell infusion. It's a phase 1 dose escalation trial. So in phase 1 trials, the standard way to do that is to treat 3 patients on each dose level. And if the toxicity is not severe, you are allowed to go to the next dose level. So these are the dose levels we tested. We started with a dose of 0.66 million CAR T cells per kilogram of patient body weight. On this dose level, we actually we ended up treating 6 patients on each dose level, because in the first 2 dose levels, we actually ended up having 1 patient with severe toxicity on each dose level. So by severe toxicity, I mean a dose-limiting toxicity. So we treated 6 patients on each dose level. And with dose level 3, we found that that was tolerable. So we did end up treating 2 extra patients with the 6 million dose. And we ended up treating a total of 20 patients on this trial. And we completed accrual early this year. This is an example of the activity of these T cells. This is a patient treated on the lowest dose level, patient 6. We gave him 0.66 million CAR T cells, and he had this large mass which was above his liver and also in his abdomen here, indicated by the green arrows. 1 month later, the mass above his liver was completely gone. There was still a little bit of residual activity in the abdomen, but then 4 months later, all the lymphoma activity was gone. He's in complete remission 18 months later. So there's certainly activity, but overall, how did it do? The overall results with efficacy were very similar to the experience with the FMC6328Z CAR. We had an overall response rate of 75%, 15 out of 20, complete remissions in 55%, 11 out of 20, and 40% of the patients, 8 out of 20, are still in ongoing responses of 5 to 29 months duration as of last week. So you can see these numbers, if you recall, are very similar to what has been found with the FMC6328Z. So when we put this new CAR into patients, we had a very similar anti-lymphoma effect. The most striking thing about this trial was only 1 of 20 patients, or 5%, has had grade 3 or 4 neurologic toxicity. So that is in comparison to 55% on our previous trial. So this was much lower than the grade 3 or 4 neurologic toxicity seen in our previous trial of the FMC6328Z CARs. So results are preliminary but promising so far. So we're in the process of doing a massive amount of correlative studies, looking at different cytokines in the blood. I can say the preliminary results show that this new CAR with the CD8 hinge and transmembrane, we have found lower levels of several cytokines in the blood of the patients compared to our previous work with the FMC 6328Z CAR. Of course, it's not a perfect comparison because they're different clinical trials, but it is kind of suggestive that we're finding the same thing we saw in vitro, where the CAR with the CD8 hinged transmembrane domain makes lower levels of cytokine compared to the CAR with the FMC 6328Z CAR. This is a paper present in preparation. We haven't really finished it yet. There's only been abstracts so far with this work. So changing the design of the CAR hinge and transmembrane and co-stimulatory domains can lead to functionally different CAR T cells. A goal of CAR research is to improve the efficacy to toxicity ratio. Targeting more than one antigen simultaneously is a promising strategy. So that's one thing we're working on now. We can make T cells that can target two different antigens at the same time. So like target CD20 and CD19 simultaneously. We also have a clinical trial of anti-CD30 CAR T cells for Hodgkin lymphoma. Great opportunities exist for further improvements in CAR T cell therapies for lymphoma. So now in part 2, we have the second major area of my work, which is treating multiple myeloma. So we have the main way we treat multiple myeloma with CAR T cells so far is with CARs specific for B cell maturation antigen, which is abbreviated BCMA. BCMA is, well, first of all, what's multiple myeloma? It's an almost incurable malignancy of plasma cells. BCMA is also known as CD269. It's a member of the TNF superfamily. It's expressed at least low levels on the myeloma cell surface of almost all cases of multiple myeloma. When we design a new CAR or go after a new target, the most important thing is to know where is this antigen expressed. If the antigen is expressed on important organs, then it's not a good antigen to target with CAR T cells because CAR T cells destroy everything that they target. So if a target antigen is expressed on an important organ, such as the brain or the heart or the kidneys or the skin or almost anything, you cannot target that antigen because you will just destroy that organ. There's been some examples of that in the past in different groups. Not very many, but a few. So we always look for expression very carefully by immunohistochemistry and PCR and maybe other methods before we target that antigen. So it turns out BCMA is only expressed on plasma cells and a very small fraction of B cells. So we theorize that patients could live without their plasma cells, similar to the way they can live without their B cells with CD19 CAR T cells. So we went ahead and designed these CARs. We designed the first ever anti-BCMA CARs in my lab, and we published this in 2013, Carpenter et al. And then we went on to do the first in humans clinical trial of any anti-BCMA CAR. We designed this CAR, which is shown below, and we used our usual process of putting it in a gene therapy vector, stimulating T cells and transducing them with a new gene, and then using those T cells to treat patients. We initiated our first in humans clinical trial in 2014. This is the CAR. It has an 11D5-3 single chain FB. That's the monoclonal antibody that this domain came from. CD8 hinge and transmembrane domain, CD28 co-stimulatory domain, and CD3 zeta T cell activation domain. So this is all in a gamma retroviral vector. This work was published in Ali et al. Blood 2016. Again, you can see the very similar setup. We follow the same pattern: fludarabine and cyclophosphamide conditioning regimen, then a CAR T cell infusion. So the patients at baseline, we treated 24 patients on this study. They were very advanced myeloma patients. They had a median of 9.5 prior lines of therapy before going on this study. 6 out of 15 had high-risk cytogenetics. 63% of the patients were refractory to their last myeloma treatment regimen. We found that patients treated on the lower dose levels had the same baseline characteristics as patients treated on the higher dose levels, so I'll go into more detail about that in a minute. But we also found that patients with higher burdens of multiple myeloma had worse toxicity than patients with low levels of multiple myeloma. So in an attempt to limit toxicity, the latter 14 patients to enroll were required to have less than 30% of their bone marrow taken over by multiple myeloma. So we measure that by doing bone marrow biopsies and we require that the bone marrow is less than 30% multiple myeloma plasma cells. So the results of this trial are shown here, and all this is published in greater detail in Brudno et al. Journal of Clinical Oncology 2018, so if you want to, you can read about it. Again, another phase 1 dose escalation trial with different doses of CAR T cells. We start with a very low dose of 0.3 million CAR T cells per kilogram of patient body weight. Then we went to 1, 3, and 9 million CAR T cells per kilogram. On the first 2 dose levels, not much at all happened. SD stands for stable disease. That means the multiple myeloma basically just stayed stable. One patient had a partial remission that only lasted 2 weeks, so really not very impressive. When we got to 3 million, we had one patient that got a very good partial remission, which in the multiple myeloma world means the myeloma decreased by 90% or more. This patient also had signs of cytokine release toxicity with fever, fast heart rate, and low blood pressure. So this was the first patient we saw where we were really convinced that we had real CAR T-cell activity. So we had to go through 8 patients before we hit that one patient that had a good response. Then we went on to the next dose level of 9 million CAR T cells per kilogram, and at this dose level there was a striking difference compared to the lower dose levels. These patients had very severe toxicity in some cases, and they had responses in 13 out of 16 patients. So you can see we have stringent complete remission, which means no evidence at all of myeloma, very good partial remission lasting 66 weeks, another VGPR, stable disease, VGPR, stringent complete remission again that lasted 69 weeks, very good PR, another stringent CR that's still ongoing, this very good PR is still ongoing. So much more response rate here. One thing you'll notice though that kind of differs from the CD19 experience is only 2 of these patients have plus signs by their numbers, which means only 2 of them have ongoing responses as of today. So a lot of the patients will get responses, but then they develop progressive multiple myeloma after a year or so. So that's one difference. So obviously the anti-BCMA CARs need improvement, so we don't want the patients to progress after a year or so. We want them to stay in remission. So we think we already have better CAR T cells than this, but we are testing them, but just to point that out. So this is an example of a patient who was treated on this protocol. The other thing to remember is these patients, once they get the CAR T cells, they don't get any other myeloma treatment after that until the myeloma actually progresses. So like a patient here that goes 66 weeks after CAR T cell infusion, he went 66 weeks without getting any treatment. So he was basically living a normal life for 66 weeks, and the patients really appreciate that they don't have to get chemo for all that time. So here's a patient number 14. He had 16 prior lines of therapy before he went to get CAR T cells, including 2 autologous stem cell transplants. His response was a very good partial remission that lasted 84 weeks. And then, unfortunately, his myeloma relapsed in his brain and his central nervous system, which is unusual. So this is his light chains. It's a measurement of multiple myeloma. It dropped very quickly. So one thing about CAR T cells is they work fast. Within a week or 2, you can usually see a response. His immunoglobulins recovered, normal immunoglobulins. He had to get 2 infusions of artificial, or not artificial, but intravenous immunoglobulins indicated by the red arrows to replace his missing immunoglobulins, because when you kill the plasma cells, sometimes the immunoglobulin levels drop in the patient's blood. Here's the same patient had this mass. Sometimes multiple myeloma patients have a mass of plasma cells called plasmacytoma. So here it is prior to CAR T cell infusion, indicated by the yellow arrow. 4 weeks after, it's much smaller. 9 weeks after, it's smaller yet. And then at 55 weeks, it was completely absent. So the CAR T cells can get rid of solid masses of multiple myeloma. Summary of toxicities. Cytokine release syndrome. This is just looking at the highest dose level patient with 9 million CAR T cell dose. The other patients didn't have much toxicity, but these 16 patients, 2 had grade 4 cytokine release syndrome, 4 had grade 3 cytokine release syndrome, and 10 had grade 2, 1, or no CRS. So we gave tocilizumab to 31% of the patients, which was 5, and 4 of those patients who also received tocilizumab received corticosteroids for CRS management or adrenal insufficiency. 1 patient required mechanical ventilation, 6 patients required vasopressors. Vasopressors are drugs that make the blood pressure go up. So low blood pressure was one of the important problems of these patients. And then the toxicity, again, was associated with high levels of bone marrow plasma cells. One issue with anti-BCMA CARs is that sometimes the target malignancy, the multiple myeloma, can lose expression of BCMA. So this is flow cytometry data for those familiar with flow cytometry. Each dot is a cell. The red area is indicating plasma cells, so that's the multiple myeloma. The purple area is just a control, it's B cells in the bone marrow. So bone marrow B cells, for the most part, do not express BCMA, so that's like a negative control for BCMA. The red population being completely off the x-axis indicates that almost all the plasma cells in this patient were BCMA positive before treatment. The patient's response was stable disease, so she didn't really have a good response to the treatment. And when we did a bone marrow biopsy 2 months later, after the CAR T-cell infusion, we found that a lot of plasma cells indicated in red down here by the x-axis indicating they did not express BCMA. So a BCMA negative population developed in this patient over 2 months. Another example of BCMA negative myeloma, this was a patient who had a long remission. He had nice BCMA positive red myeloma cells before treatment. Then 56 weeks later, we detected a small population of BCMA negative. So see, they're negative, they're near the x-axis and they're equal with the B cells. But then after 68 weeks, it kind of diversified where we had some BCMA negative and some BCMA positive. So multiple myeloma is a very complicated disease. Sometimes it can develop subclones within the same patient. So there can be different phenotypes in the same patient. And this has definitely happened here with this patient. We have some BCMA negative and some BCMA positive cells. So in summary of the anti-BCMA CAR T cells, 2 of 10 objective responses at dose levels 1 to 3, but 13 out of 16 objective responses at the optimal dose level of 9 million CAR T cells per kilogram, with an 81% overall response rate on the optimal dose. So we can see this is an example of dose dependence in the cell therapy field. The higher doses work better. We had 4 out of 16 patients on the optimum dose have durations of remission greater than a year, plus 1 ongoing at 41 weeks. Durability is not as good as the best anti-CD19 CAR T-cell therapies for lymphoma, however. So multiple myeloma is difficult to treat because of its phenotypic heterogeneity. This was the first anti-BCMA CAR and improvements are underway. So to improve that, we are now testing a CAR which is fully human. Again, that previous anti-BCMA CAR had mouse components, and now we have a fully human CAR which is made up only of an antibody heavy chain. There's not a full single chain FV, which usually contains a heavy chain linker and a light chain. This is just a heavy chain only. So this is a diagram to explain that. This is a new CAR that we've designed in my lab, and we're testing this. This is a heavy chain binding domain made in a transgenic rat, which we obtained via collaboration with Teneo Bio. So this is a heavy chain, fully human binding domain. And then we have CD8 alpha, 41BB co-stimulatory domain in this case, and CD3 zeta T-cell activation domain. This is in comparison to a traditional CAR, which has a single chain FB with a light chain, linker, and heavy chain. So you can see it's fully human. So that's one good thing about it. That will decrease immunogenicity. It does not have the linker, which is also a way to decrease immunogenicity, and you eliminate 2 junctions. So these junctions between the light chain, the linker, and the linker and the heavy chain are potentially immunogenic, and so we eliminate them by using this approach too. Other important differences are the 41BB instead of CD28 in our previous work. So this is just showing that if we look at the 11D5-3 traditional CAR, the single chain FV versus the heavy chain, there's really minimal difference in cytokine production. You can see these bar graphs here. The P was only 0.02 for TNF, but it's really not that big of a difference, and there was no significant difference for interferon gamma or IL-2. They both proliferate, but the number of cells that accumulate, I'm sorry, this is talking about difference in the co-stimulatory domains. We compare 41BB to CD28. And basically, we did proliferation assays in vitro where we labeled the cells with a dye called CFSE. We put them in culture with a target cell that expresses BCMA. Then we looked to see how they proliferate. We found that there was no difference in dilution of CFSE, which indicates no difference in proliferation, but there was an increased accumulation of the the CARs with 4-1BB. So why would that be? We found that the CARs with the 4-1BB moiety were much less likely to undergo apoptosis. So we think that the reason why more 4-1BB CAR T cells accumulate is because of a resistance to death by the 4-1BB CAR T cells, which is consistent with previous work done by others. And we found a greater accumulation of these 4-1BB CARs in vitro very consistently. You can see here, this is the 4-1BB CAR FHBH33CD8BBZ. After a 7-day in vitro culture period, there's a nice strong population of CAR T cells and a Nexin-5 positivity indicating apoptosis only in 12.5% of the CAR T cells. If we look at the CD28 CAR, we have this kind of much smaller population, and out of this population, 41% were a Nexin-5 positive indicating apoptosis. This was found in 3 out of 3 patients with higher levels of apoptosis in the CD28 expressing CAR T cells. And the total number of T cells was also higher in the, if we just look at accumulation of total number of CAR T cells, it was much better with the 4-1BB with in vitro culture. We have some preliminary data showing the same thing in mice, but that's not really ready to present yet. In the mouse model, as far as efficacy goes, we had established tumors of RPMI-8226 in NSG immunocompromised mice. At day 0, we treated the mice with the CAR T cells, and we found that all 3 CARs, the 11D5-3, the FHBH-CD828Z, and the FHBH-CD8BBZ, all were capable of eradicating tumors from mice and leading to survival. If we look at a different model, which I didn't bring today, we have a disseminated model, and in that model, the 4-1BB CARs are actually superior to the CD28 CAR. So this is just kind of an introduction to what we're doing currently. We have CAR T cell therapies are all at an early stage of development for multiple myeloma. So there's a huge amount of progress that can be made, a huge amount of more work that we'll be doing. Improvement is anticipated. We just opened up a clinical trial. We treated the first patient last week on a trial of this FHBH33CD8BBZ heavy chain only CAR. We'll start treatment on the next patient tomorrow. It's a dose escalation trial with a starting dose of 0.75 million CAR T cells per kilogram. I just want to thank all my coworkers, first ETIB with my boss Ron Gress and all my other ETIB coworkers, Department of Transfusion Medicine, industry collaborators Kite Gilead, pathologists, and surgery branch led by Stephen Rosenberg. And again, disclosures, I have research funding from Kite Gilead and Celgene and multiple patents in the CAR field. Thank you.
So I know there's lots of trials going on now about using CAR T cell therapy in solid tumors. How is that going?
I don't really study solid tumors. I only study hematologic malignancies, but I think it's a lot tougher to treat solid tumors. And the main reason is because there's not as many great antigens. So with the hematologic malignancies, we have some really good antigens like CD19 and BCMA, but in solid tumors, the antigens tend to also be expressed in other normal organs, which is a big problem. Perhaps there are a few good antigens, but they're much harder to come by. Also, there could be differences with the solid tumors as far as the T cells penetrating the center of big solid tumor masses, although we know they can eliminate lymphoma and myeloma solid masses. But the solid tumor area is very much farther behind the hematologic malignancies in CAR T cell work.
Okay, that'll do it.
All right, thank you. Thank you very much.